Okay, thank you, Masa, for the introduction. So I'll be talking from the poster that we presented at UniNR in Vancouver, Canada, it's in February of this year. The title is Performance of KFT Plus in a Public Health Setting in King County. Next. Oh, I can use this. I have no disclosure. So I hope at the end of this presentation, you will learn about the current assumption in the interpretation of TB1 and TB2 for the KFT Plus test and how to apply the test results to make a clinical decision for treatment purpose. And also you'll be able to identify some risk factors that are associated with high gram-positivity and high delta. I'll talk about high delta on the next slide. So King County switched to using KFT Plus in November of 2017. As you know, KFT Plus was approved by FDA in June of 2017. So probably our lab probably is the first lab to use a KFT Plus in the nation. So we looked at the data that was collected from November 2017 to October 2018 on patients that have a KFT Plus done at our public health lab. These are mainly from the refugee and TB clinics. So the cohorts includes refugees, asylees, and those who came through special immigrant visas that were seen at the refugee clinic, and then class B1 in contacts that they were seen at the TB clinic. So this is a slide that I borrowed from the manufacturers with their permission, just to show you the difference between the KFT TB Gold and the KFT Plus test. So on the KFT TB Gold, if you see, there is only one antigen tube, and it has three antigens, the ESAT6, CFP10, and the TB7.7. These are mainly designed to induce the CD4 T cells. The new one, the KFT Plus, has two antigens. The TB1 antigen is similar to the KFT TB Gold, which has two of the antigens. On the new one, the TB7.7 antigen is absent. So the TB1 antigen measures CD4 cells activity, but the new one, the TB2 antigen, has the long peptides, which are the ESAT6 and the CFP10, but in addition, it has also the short peptides that are designed to stimulate the CD4A T cells. So just to summarize, so the new KFT Plus has only two long peptides, the ESAT6 and the CFP10. The additional tube contains short peptides in addition to the CD4. They are designed to stimulate the CD8 T cells. In the KFT Plus, you can collect blood samples directly into 4 tubes, or you can use the lithium heparin tube. And also, if you collect the blood in the lithium heparin tube, you can refrigerate it overnight and process it the next day, which was not possible with the KFT Gold test. So initially, our goal was to assess the performance characteristics of the KFT Plus test in diverse risk groups that come to the public health clinics, and also to identify some of the risk factors associated with high delta. So delta, this is a concept to define the activity of CD8 cells. As I mentioned earlier, TB2 measures the activity of CD4 cells and the CD8 cells, but the TB1 also only measures the CD4 cells. So if you subtract, and if the measurement is greater than 0.6 international unit, the assumption is that it signifies CD8 cells activity. So what is the significance of CD8 T cells? Well, there are studies that are showing that it's most frequently detected in active TB cases. And actually they have compared between a smear positive, culture positive, and a smear negative culture positive case. And they have seen more CD8 activities in the smear positive and culture positive case. So the assumption is that if you see a CD8 T cell activity in a latent TB case, this might signify some kind of bacterial activity, and probably they might progress to develop active TB soon. And then the other assumption is that it's mostly seen in patients that have been diagnosed with latent TB recently. So I just want to caution that this cutoff value for signifying CD8 response is not well established. I think there are only a couple of studies that came out with this cutoff point, and I think everybody's following after that, but it is not established. So we had a total of 1,625 patients were tested from November 2017 to October 2018. And out of those, close to 22% were positive. And we have 11 cases of indeterminate results, which is about 0.7%. So we had patients who have a second round of testing, which were contacts, and also some of the indeterminate results had also repeat test done. So overall, we had 363 patients who had a positive test results, which is 22%. So we used the final result to do the analysis. So here we had 5 risk groups. So the blue color shows the number of people tested in each group, and the orange one indicates the number of positive results from each group. And then the red numbers shows the percentage of positive results in each group. So asylees, as you know, these are individuals that are admitted to the United States and are allowed to stay because of fear of persecution in their country. And this cohort, almost 60% of them, they came from high-risk country, and almost 70% of them are from sub-Saharan African countries. And the refugee group, most of them are from Ukraine and Afghanistan, almost close to 70%. And the SIV, those who came through special immigrant visas, these are mostly from Afghanistan. Most 98% of them are from Afghanistan. As you can see, there is a high positivity rate among Class B as expected, followed by asylees, and then contacts. So this is just to show you the agreement between the TB1 and the TB2. As you can see, the discordant results, which have it's circled in red, are about 44 out of 1,617 test results. So it's kind of high. If you look at the kappa coefficient, it's about 0.91 with a narrow confidence interval. So out of the positive results, which are about out of the 363, 88% of them are positive by TB1 and TB2, about 5% by only TB1, and 7% about by TB2. So I didn't see any major demographic difference between those who tested by TB1 and TB2. The only thing which I noticed was that if you look at the median value of the TB1 and the TB2, for example, when it's positive by both, the response was very high. For example, for TB1 was 3.9 and the TB2 was 4.2. But when it's positive only by either TB1 or TB2 was kind of low, which was 0.5, which is kind of close to the cutoff point to say positive or negative, which is 0.35. So we looked at the data by gender, by demographic, by different age groups, and by the risk groups. So these are the factors that were positively correlated with positive KFT results. So meds have a higher probability of having a positive results. Out of the age groups, those who are older than 64 years old had a high probability of positive results compared to those between the age of 1 and 17. When you look in the risk groups, Class Bs have the highest compared to those who came through special immigrant visas, followed by asylees and then contacts. So when you throw all the factors that I mentioned about these three factors remain persistently, significantly associated with positivity, contacts, followed by asylee, and then those who are older than 64 years old. So we also looked at delta, the CD8 cells activity. So by age group, as you can see, those who are older than 64 have a significant amount of delta in their group compared to those between the age of 1 and 17. And then if you look at under the risk groups, Class B's ones have the highest, followed by asylees and contacts. But when you throw in all these factors, contacts remain significantly associated with higher delta. And this finding is kind of supported with other studies. There are I saw 2 studies which support this hypothesis. So in summary, overall the agreement between the 2 antigens, the TB1, the TB2 was high. So being a contact, asylee, and those are older than 64 are strong predictors of positive KFT class results. Class B1, asylees, and contacts are significantly associated with greater TB2 response. And also contacts association with high delta persisted in multivariate analysis. So in conclusion, our finding is consistent with previous reports that found that contact has an increased proportion of high delta, and age greater than 64 and Class B1s are also associated with high proportion of delta, and I think this association needs to be explored further. So the limitation, in Class B with normal chest X-ray or abnormal findings consistent with non-TB condition may have affected the strings of association. And also, the different blood sample collection methods also might have affected the outcome. For example, at the TB clinic, we use heparin tube. and at the refugee clinic, they use 4 tubes. And also, sometimes we refrigerate samples overnight. So we don't know, like, if this has any effect on the outcome.
Great, thank you, Joseph. So before we go to questions, we have a case study. So here we have a 70-year-old man from Vietnam who is a recent contact of an infectious TB case, and that was his son, who is 40 years old, smear positive cavitary TB disease. And his quantiferon results are shown here. Everybody is looking very closely. Everyone get ready. We're going to have a question pop up. All right. So given this individual's risk factors, we have a contact, given the quantiferon results that are in front of you, given what you know now from Josef's talk, would you initiate LTBI treatment? The first one is no. Second one is yes, but only if rifampin, if we can use rifampin daily for 4 months. Yes, if the next one is yes, if either INH and rifapentine or rifampin daily. Our next yes, any of our options. So we have isoniazid, rifapentine, and rifampin.
Yeah, and let me kind of help you interpret the numbers, right? So first of all, mitogen is greater than mitogen minus nil is greater than 0.5. So that's good. Nil should be less than 8, so that fits. And then you do a TB response. TB1 minus nil, so 0.32 minus 0.02 equals 0.30. So that doesn't meet the 0.35 criteria. So looking at the TB1, that's not impressive. And then if you look at the TB2 minus nil, that is 0.95 minus 0.2, right? That would be 0.93. Greater than 0.35, so therefore using a TB2 minus nil, it's positive. So you get the report saying it's positive, right? And then this proposed advantage, right? Nobody has validated what this delta means. But what Joseph was saying was if the delta TB2 minus TB2 greater than 0.6, which is the case here, indicates either recent infection or more bacterial burden. Right? And then back to the situation, so 70-year-old from Vietnam, this infection can be remote. Maybe he caught TB back in Vietnam, or his son, household contacts are highly contagious case, and therefore we may want to interpret this as a recent infection, even though he is from Vietnam and he is 70 years old, right? And then this is one of those kind of dilemma, right? Okay, yeah, QFTA plus is positive when you test the contacts. Do you want to treat or not? Usually, yes. But does age age 70 influences your decision? If so, how far do you feel comfortable? Rifampin is supposed to be least hepatotoxic. INH rifapentine second, and INH alone is most hepatotoxic. So how far can you go to treat this person?
Thank you, Masa. Hopefully he didn't give our answer quite, just kidding. I mean, but guided. Great, so we have 11% of us said no, 22% of us said rifampin, 22% of us said INH rifapentine, and 44% said we're gonna use any LTBI treatment option. Great. Masa, are you surprised by
No, I
these?
think I'll be curious about the input and thought process from the eco community.
Great.
Yeah.
Oh yeah. So you just have a few more slides, right?
Do I have one?
Yep. Yep. Oh yeah. Sorry. Yep.
Yeah, so I have added some reference for if you want to read more about the KFT Plus studies that were done recently. We don't have that many studies done in the US since, I guess, the test was approved recently, but in Europe, I think it was approved in 2015, I think. And also, I just want to thank well, Masa and I will worked on this, but I think Chris and Dave are going to join us writing the manuscript. And also, I want to acknowledge Meg and Laura, who helped us with data entry and also in processing the IRB approval.
Great.
Thank you.